Good evening, everybody, and welcome to Improving Prostate Cancer Care with Unfold Artificial Intelligence, Creating a More Personalized Future. Unfold AI combines patient-specific data, MRI, PSA, biopsy, and pathology, and artificial intelligence to characterize the patient's prostate cancer. It shows how far prostate cancer extends within the prostate in the form of a 3D cancer estimation map, and each cancer estimation map is tailored to the individual professional. We are delighted to have Dr. Kasraeian, I hope I pronounced that right, who is a board-certified urologist in Jacksonville, Florida, and a fellow of the American College of Surgeons. He is joining us this evening with a little bit of a time difference. I believe he's on the East Coast right now. Named among America's top surgeons, he completed a prestigious fellowship in advanced laparoscopic, robotic, and minimally invasive urologic surgery at the highly acclaimed Montsouris Institute in Paris, France. Dr. Kasraeian specializes in the advanced diagnosis of prostate disease and is a leading expert on minimally invasive and ablative urologic surgery for prostate, kidney, bladder cancers, as well as benign prostatic hyperplasia. And we welcome, with 30 years of experience in the medical imaging industry, Ms. Reul, I hope I pronounced your name right, has extensive experience in ultrasound imaging and guided intervention in urology. She has particular expertise and specialization in imaging of prostate cancer.
Before introducing our speaker, a quick word about the Prostate Forum of Orange County. The Forum is a group of men who themselves are dealing with prostate cancer and who want to support anyone else who is dealing with the disease. We do this by offering information, education, and hope through our website, prostateforum.org, and through monthly support group meetings and presentations by experts. There are 2 online support meetings each month. The first, mainly for those newly diagnosed with prostate cancer, meets on the 2nd Tuesday of every month, and another meets on the 4th Tuesday of each month, mostly focused on advanced and recurrent prostate cancer. Both meetings are free and open to anyone affected by prostate cancer. In addition to these support groups, we also offer on most months talks by experts in the diagnosis and treatment of prostate cancer, just like tonight's presentation. Topics from these experts range from diagnosis to active surveillance to radiation, surgery, side effects, genetics, and other medical advances. You can learn about upcoming presentations at prostateforum.org/speakers or view previous presentations at prostateforum.org/presentations or on our YouTube channel at youtube.com/@prostateforumoc. To take advantage of these resources, we encourage you to sign up to receive announcements of meetings, presentations, and newsletters. And when you're ready, please consider helping us help others who are dealing with cancer. We're all volunteers, and we invite you to volunteer some of your time and expertise with organization, coordination, marketing, website maintenance, whatever you can. Whatever you can give will really help. And even though our volunteers are not paid, our expenses are very real. Your donations will help us to continue providing education, information, and hope to men with prostate cancer and their families and friends. With that, let's turn to tonight's speaker.
I would like to take this opportunity to thank Dr. Metzger and Mr. Burke for inviting me to speak today at the Prostate Forum of Orange County. My name is Carolyn Reul. I've been involved in the urology imaging market in one capacity or another for over 30 years. I left the corporate world 2.5 years ago to join Avenda Health as VP of Sales and Marketing. It was a big move to go from the corporate world to a startup, but I experienced that in the corporate world, innovation can move at a glacial pace. And what I've witnessed at Avenda Health is nothing short of remarkable. Avenda Health is an extremely dynamic software company that's using deep learning AI to create a more personalized future for prostate cancer care. In the last 2 years, we have not only received FDA clearance, but have also been awarded a CPT code. And believe me, this is not the norm. This tells me I made a very good decision, and that I'm not alone in seeing that Unfold AI is the most impactful tool to assist in the management of prostate cancer to come to urology in decades. I am very excited to tell you all about Unfold AI, our revolutionary AI-powered decision support and prostate cancer management platform. So let's get started. As I am sure you are all aware, besides skin cancer, prostate cancer is the most common cancer in men. There are more than 3 million people living with prostate cancer in the United States today. A major challenge in determining the best care path for prostate cancer management is reliable diagnostic imaging. It is not surprising that even the most skilled radiologist can underestimate the extent of prostate cancer when you consider that 68% of tumor volume is invisible on MRI. To preserve quality of life and avoid leaving cancer behind, doctors need to know where the cancer is within the prostate and to confidently know where it is not. An unfortunate consequence of not knowing the likely extent of the cancer is it can lead to wrong decisions, which can affect a patient's quality of life post-treatment. Quality of life issues are not limited to continence and potency. Anxiety and depression can also factor in. So as you can see, decision-making in prostate cancer is hard. Every patient is unique and should be treated as an individual. The difficulty for the physician is the patient's information is scattered across the healthcare system. The radiologist reads the MRI in the radiology department. The pathologist interprets the biopsy results in the pathology department. And the urologist and oncologist are tasked with making their assessment by reviewing these reported findings, along with additional factors like genomic testing, genetic testing, family history, etc. They have to put it all together and create a picture in their mind, and then figure out what is this patient a good candidate for? What are the best treatment options? And make this decision before they counsel the patient. The patient and their family often have done some research and have an idea of what they think would be a good treatment option. Their friend had a focal therapy or a radical prostatectomy, but is this their best option? Are they really a good candidate? It's a tough decision and it's stressful. Unfortunately, the existing tools don't always provide enough information to make a truly confident decision regarding which treatment strategy is best. Wrong decisions generally have some degree of consequence that affect quality of life. Wouldn't it be nice to be able to see what's happening in the prostate and discuss your options with a clearer understanding of what are good options and, more importantly, what are not? So how do we do it? We put your clinical data, including your fusion biopsy, MRI, PSA, pathology, and demographics, into Unfold AI, our decision support and prostate cancer management platform. Unfold AI uses more than 1 million data points to assess your entire prostate to generate the first output, a 3D cancer estimation map, or CEM. To create the cancer estimation map, the algorithm labels every voxel of the prostate with a color indicating the likelihood of clinically significant cancer, red being the highest likely to be clinically significant, and blue representing the least likely. The color gradients out from red to orange to yellow to green to blue, providing a clear representation of what is likely happening in your prostate. Unfold AI defines clinically significant cancer as Gleason grade 2 or higher. This grading is determined by the pathologist from the tissue retrieved during the biopsy. The second output of the algorithm is a lesion contour. The lesion contour delineates the area of the prostate in 3D that will ensure the highest likelihood of encapsulating all clinically significant cancer. This contour is optimized and unique for the individual, unlike standard of care methods that simply create a 1 centimeter margin around the region of interest and hope that they've captured all of the clinically significant cancer. The AI-generated estimation map and lesion contour provide critical information regarding tumor staging, tumor volume, treatment risk, and treatment planning. And they bring high confidence to the decision-making process for selecting the best options for your unique situation. The workflow is straightforward. After the patient is diagnosed with Gleason grade 2 or higher prostate cancer, their clinical information is synced with Unfold AI in the cloud, and the CEM and lesion contour are generated. After the physician does the initial review, the information is shared with the patient during the consult. At this point, joint decisions are made regarding the overall care plan and next steps. As you can see in this slide, the MRI underestimates the size and shape of the tumor. The extent of the tumor is invisible, and it is understandable that it can be missed. Unfold AI took the patient's clinical information and was able to detect the true extent of the tumor. The image on the right shows the pathology findings, so it's easy to see that Unfold AI's algorithm is accurate. As you can see, we have conducted several validation studies, all of which were statistically significant. If you're interested in obtaining copies of any of these abstracts, please let me know, or simply visit our website at avendahealth.com. So in conclusion, by using AI and integrating imaging, fusion biopsy, biomarkers, and pathology to visualize the extent of cancer in 3D and providing a tumor margin for treatment, Unfold AI empowers the physician by providing the much-needed tools to determine the optimal treatment for the patient and strategizing the optimal approach for treatment success. I see Unfold AI as the new superpower, not only for the urologist and the oncologist, but for the patient as well. Thank you.
Thank you very much for having me. I apologize for being in the corner here and looking at this. I'm in the middle of flying to another conference, and currently there's an emergency going on in the Atlanta airport, so I apologize for the sound. So I hope you can still hear me. But what I want to share a bit is and follow up to Carolyn's wonderful presentation is how powerful this information is that we get from Unfold AI to help us as urologists and in concert with our discussions with our pathologists, our radiologists, to be able to take what our MRI scan gives us and what our pathology gives us. Where a lot of times, as you see here on the slide, all three of these patients had lesions that were on the MRI scan that could be on initial glance without Unfold AI amenable to focal therapy. And that's where from our perspective, the use of Unfold AI came into a decision to, hey, well, let's use this and see if it can benefit us in the discussion, especially early in the experience of seeing how it would benefit me as a urologist in the practice after the initial excitement of being able to use this from that standpoint. So you have a patient that comes in with an MRI lesion, like, for example, you see on the top picture, very small lesion targeted with an MRI scan that nowadays, most of my personal practice, MRI driven, where you do an MRI scan beforehand, finds an area on the MRI scan that is amenable to doing a targeted biopsy, combined with a standard biopsy. So you're very confident that only that area has cancer, and you come back and talk to the patient, and they're very interested in trying to preserve as much of the prostate as possible in order to preserve as much function as possible. A big discussion in prostate cancer right now. Can we monitor the prostate cancer with active surveillance? Should we perform a more whole gland therapy like a radical prostatectomy or radiation therapy? Or can I be a candidate for focal therapy options? So the more prostate you preserve, the more function you preserve. This technology allows us to really have a personalized discussion with our patient as to their candidacy. And it's very important for us to be able to not only give the patient and ourselves the confidence to know that a focal therapy is going to be a wonderful therapy for them, but also to be confident in talking to our patients about the fact that it may not be a great option for them, like, for example, the patient in the bottom picture. So all of these patients have a focal area on an MRI scan. It was targeted, had a low intermediate risk prostate cancer, like a 3 + 4 = 7 prostate cancer. And I'll explain what that means for a member of the audience that may not know. And with the Unfold AI, you take all that information in, well validated, all the large volume of patients put into those studies, and the graphs that you see on the left give you confidence that with that margin, that purple line that you throw around there, if you are able to treat within that margin, you can have, in these cases, let's say an 85% confidence that the treatment you provide is going to offer them a valuable cure of their disease. And you can actually, in a wonderful tool, you can actually move that number around so that you can have a very personalized discussion with your patient and their comfort level for focal therapy. So as that pink dot moves over to the right, their candidacy for a focal therapy decreases because you have to treat more of the prostate to be able to get a curable pathway towards the treatment that you have to provide. So as you can see, the patient in case A, they have a very small lesion. If we treat that corner of the prostate with a very nice margin, we can not only offer them a very good cure, but we can preserve most of their prostate and offer them a very nice focal therapy. In the patient in B, we can probably offer them a focal therapy as well. However, their disease is a little bit bigger. So it's a little bit of a different conversation. However, in patient C, we can be very confident and talk to them about the fact that they're probably a much better candidate for a whole gland therapy. So as a urologist, this is very, very important and impactful for me to be able to not only counsel my patient that you're a wonderful candidate for focal therapy, and I can be confident that I can treat you and monitor you well, and our follow-up imaging can give me confidence in terms of what the future looks like, because I can offer this technology in combination with standard of care tools that we already have. But I can also counsel the patient at the bottom that I don't believe that focal therapy is going to offer you the best cure, because we can't provide you the treatment benefits without risking not offering you a treatment that's going to treat the disease the way that it needs to be treated. Because at first and foremost, we want to be able to manage the oncological principles of what we're doing with focal therapy, and that's a powerful tool to offer our patients. And before, we did not have a technology like this to be able to offer our patients and to be able to do it in real time. I can do this biopsy as soon as my results come in. I have an MRI scan, I have the pathology, I can plug this in and in real time have this discussion with my patients. And that is incredibly powerful. So when we look at this, this makes me I think a smarter urologist with the management of prostate cancer. It makes me be able to have better conversations with my radiologist. It allows me to learn better. So I often sit down with my radiologist and we compare our pathology with what the images look like beforehand. This elevates that further. So not only am I a better patient advocate, do we have smarter conversations with our patients, but now we can go back and learn from what we are currently doing to make us better in the future with the technologies that we're currently using, but also our application of novel technologies like this for how we do things in the future. So I think this is something as a patient would be something to ask your urologist about, or ask Carolyn about, and ask people like me who are engaged about using these things, of how we can incorporate this in your decision-making process, because it allows you to make smarter decisions about what to do. And, the thing to think about in terms of, if you have any questions about how to find a urologist that employs these technologies, Unfold AI and Avenda Health have a patient locator. I'm sure Carolyn can speak to that a lot better than I can, to find urologists around you or in your region that are using Unfold AI, so you can have conversations about how this can be a tool that can help you make better decisions. Because at the end of the day, I talk to patients about, 4 kinds of prostate cancers: rockets, rabbits, turtles, and snails. And rockets are the prostate cancers that show up when it's already metastatic and out of the prostate. Really, the whole reason we screen for prostate cancer is to avoid metastatic prostate cancer. Fortunately, it's very rare, but it's not unseen. And unfortunately, since the U.S. Preventative Services Task Force recommendations against screening, we've seen a stage migration, and we see more advanced disease. We see more high risk disease, and we're seeing situations like that. This week in the news, we unfortunately saw that Martin Luther King's son passed away at 62 years old of prostate cancer, and that's heartbreaking to see. The prostate cancer that we treat are the rabbits. Prostate cancers that have legs are confined within the prostate, but they could potentially change in the future. So our best shot is to catch them when they're diseased that can be treated within the prostate. And by treating them, we avoid the possibility of them getting out of the prostate in the future. Then we have the slower growing cancers, the turtles and the snails, the ones that most often we can manage with active surveillance and monitoring. And there are studies that have shown that that's a very, very wonderful management option. Not all patients are comfortable with that. Then you have things like the 3 + 4 = 7 prostate cancers. If you think about 7, the Gleason 7, which is a grading scheme, it's like a fence that divides more aggressive cancers like 8, 9s, and 10s, which are a little bit more aggressive cell type, from the less aggressive cancers like the Gleason 6s, which are the very, very, very less aggressive, slower moving cancers. When the first number on that scoring system is a 3, it's less aggressive than if the 4 is. Kind of like the side of the fence leaning towards a less aggressive cancer, where if the 4 is first, it's the side leaning towards the more aggressive cancers. So when we have a small volume, 3 + 4 = 7, for example, like the picture in A at the top of the page, can we potentially just treat the portion that has the cancer? Think about it philosophically, like we're expanding active surveillance, and monitor that patient and give them more years of life with better quality of life. And if we can safely do that and be able to not only cure the cancer with confidence, using technologies like Unfold AI, which give us even more confidence because we have a better understanding of the biology and the potential future prognostic behavior of that cancer by how we treat it now. That makes us a much, much, much smarter in terms of being able to meet the goals of our patients. And I think that's where this technology is really valuable for patients and urologists to bring to the table of how we talk to each other about how to manage your disease as someone who's dealing with prostate cancer, which is a very difficult cancer to manage when you're first diagnosed, because it's very confusing. There's so many different things that you can potentially do. Each has their own very individual risks and benefits, and everyone you talk to has something that they favor. Friends that you talk to have things that they've done that they find is wonderful, but it's so individualized. The size of your prostate, the cancer that you have, the volume of the disease. So a tool like this allows you to visually see what's going on and be able to have a very intelligent, very data-driven, and very visually observable decision in terms of what to do that's personalized to you, your cancer, and ultimately your goals for what you want your cancer treatment to look like. So I hope that's helpful in terms of how I view the value of this in my discussions with my patients who are considering focal therapy when they're candidates for it, to make sure that they are actually very good candidates for it, both oncologically and making sure we can preserve the portions of their prostate that would make them have the quality of life outcomes that they want.
Thank you very much, Dr. Kasraeian and Ms. Reul. We've got kind of a conversation started already. We're going to start off with some questions that have been asked by Adrian, and some of them have been answered too. Adrian wanted to know what is the Unfold AI information in the cloud? What is the source of it? And of course, is Unfold covered by Medicare? And he further continues, I assume that Unfold AI is only as good as what's included in the information base. And then I believe Mr. Reul answered him by saying Unfold AI is accessed via the cloud. So the physician does not have to be in our location to use it. It is not currently covered by Medicare. We are positioned to have reimbursement by July, August of this year, 2024.
Could we elaborate on that?
Yes, please.
Yeah,
Absolutely.
this is Adrian. Let me just say what I was talking about on the
Mhm.
accessing in the cloud. You said it's based on the second step was it uses the AI, the unfolded AI information in the cloud. Well, where do you get all that? You know what I mean? It's what's good in it's
How does it get in there?
Yeah, how's it get in there, and how do you know, and how do users know? That's a comprehensive. I have no idea how AI works and where it gets all the stuff it gets, but how do you know that that base is comprehensive?
Okay. So basically, the first thing is that a cloud-based software just means that you can access it anywhere. There isn't a seat, like you don't have to be in one place to do that. There are certain softwares that they give you one license and you sit down in one location and you have a monitor. That's not how this works. This is cloud-based, which means that you can access it from wherever you have a laptop or access to the internet. The components that go into Unfold AI are your MR fusion biopsy, your pathology information, and your MRI information, and then demographics and stuff. But basically, that's inputted into the algorithm that's actually physically put into the software. And then the algorithm takes that information, processes it, assesses your entire prostate, and is labeling each voxel of the prostate with the indication or color that indicates the likelihood of clinically significant cancer. So the inputs are done by various methods, but basically things are moved from the fusion biopsy device, generally via Ethernet, or could even be through the internet. Everything's encrypted. All patient information is protected, and it basically moves into the software. So does that answer the first part of the question?
It doesn't make sense, but I assumed that my information, if this was it would come in some way, and my doctor would submit it. And I'll tell you a story about him in a second. But no, I was more concerned. Concerned is the wrong word. I was more inquiring about. Okay, so I sent that stuff gets sent in, and there's this really smart AI stuff. Who made the AI so smart that it can do all of this?
Well, we have some pretty amazing engineers at Avenda Health.
And that's who puts that all together.
Correct.
Join the meeting.
An architect, basically. It's our scientists, our data scientists, basically are the architects of the software. They built the software. And this algorithm and the strength of the algorithm is based on the amount of data that it actually has to process. And I can't really explain all of that.
Okay, no, that's I just assumed something like that. I heard this. Neil or someone suggested that we had heard this earlier month and a half ago about your thing. So I went the next day, literally, I had a virtual with my urologist, and I said, Dr. Spratz is doing something different than this. He's doing ADT and whether to use it or not. And then this one is more diagnostic, where it is, make sure you get all that. Talking to him, he said, "What's the name of that again?" I said, "Unfold AI." He turns, looks in his computer, and sends off an email to you all. Want to know more about it, so he can decide which he's going to do it, because I'm going to make him do it. But
excellent.
But it
what was
just
his name?
Daniel Bratt.
Daniel.
No, the other guy.
Okay.
No, that's it. My doctor's name is
Yeah, your doctor.
Rahit, Rahit Jain, Jain. He's at George Washington University Medical Faculty Associates. So he just punched it off and said, "I'll tell you about it." He had not heard about it, and so maybe part of your thing, and he's sort of way up the scale in knowing about things, if you know what I mean. But just had not simply hit the word and got to him. And he looked at it real quick and said, "Well, I better find out about this." So that's just a good thing.
That's a great thing. Thank you for sharing that with him.
Clarify then this. So you guys have built this massive database, what we call learning, given it the learning information just about facts that are known. And then you get my data or you get somebody else's data, the patient's data, and you kind of dump that on top of it and say, go tell me how what I've just given you relates to all the core information that you have in there. Is that simplistically how the thing is being done?
Yeah, it's basically looking at information about millions of data points about prostate cancer, and it's creating a probability map. That cancer estimation map is basically telling you about the likelihood of clinically significant cancer. And as I mentioned, that's GG2, Gleason grade 2 or higher. So the red and the blue is not an indication of it's an indication of how likely it is to be cancer. And the algorithm is so strong that it has been pretty spot on doing the assessment and then lining it up with the pathology after a patient has had a prostatectomy. That's how it was validated.
It's based on a philosophy that, when we look at MRI studies, many studies over the years have come up and showing, what does your margin have to be confident in a focal therapy that you have not undertreated the area so that you can maximize your confidence and that your cures are going to meet similar outcomes as whole gland therapies for that area, assuming that there's no other cancer anywhere else or no clinically significant cancer, meaning grade group 2 or higher. And so, there's conjecture that potentially MRI scan could underestimate the totality of the disease. And so we talk about margins that are, some talk about 1 centimeter. There are studies that talk about 1.6 centimeters. So what Unfold AI is doing is using all this amazing clinical input to give you this wonderful, personalized, predictive modeling that has been well validated. Like she mentioned it with the prostatectomy model, and that slide that you showed was a beautiful representation of that, where they had a very small lesion on MRI scan that was targeted, that was found to be a cancer, and then when the prostate was removed, there was a bit more significant cancer from that standpoint. So that being said, if someone used the artificial intelligent technology based on the information that has been put into getting us to this point, then you use that with the patient's personalized information, and you come up and have a conversation. So you have this very focal lesion that we found on your specific biopsy based on an MRI scan, and we treat this much of the prostate with a focal therapy. We have 85. If someone wants a better percentage, 90%. If we treat more, if someone's more comfortable with a smaller percentage, we can move that pink dot over. We can come up with a gradient of confidence that if we do X amount of therapy, we can be very confident that we can offer this much cure. And that's the concept behind how to use this technology based on really well validated study of the reality of what the MRI scan shows, what the biopsy shows, and what the prostatectomy data showed. And that data was used to create this technology.
Got it. Thank you.
So I saw that there was a couple of...
I have a question.
Sure.
As a long-term patient of Dr. Marks at UCLA on active surveillance, I recall that he was that he developed some sort of a company. Is that the company that was a spin-off from UCLA?
Correct.
So
Avenda Health spun out of work from UCLA.
Yeah. So what, like when I was, a lot of the patients were Gleason 6 and some were 7s. So did you segregate the ones that are 7 so you could do the focal, or are you looking at the 6s and 7s and everything else?
We look at GG2 and higher. So anything.
Okay, so you don't look at the ones that are 6s then. You just look at the
yet.
ones.
Not yet. We are actually working on the algorithm to look at GG1 as well. It'll be a future version of Unfold AI.
Stay tuned.
Anyway, you could thank me for your, for your company, because I contributed lots of samples.
Well, thank you.
Let me
If
just
I
make
may,
understood that. You don't have the algorithm to do for 3 + 3 6s, is that right?
Correct. Right now, we do not have, we are not set up. It'll show on Unfold AI. So that is an input. We look at 6 plus GG1 as an input, but we are not set up for creating the cancer estimation map. We need to have at least one core, biopsy core of GG2 cancer in order to create the cancer map. And not too distant future, we'll be able to deal with GG1.
Okay, well, so maybe it's a good thing I can't use it. I can't use. Oh darn! I can't use it. Let's go find a GG2. Come on, let's do a better biopsy.
Neil, I have a question.
sure. I'm going to go to Dr. Metzger, and I'm going to come back to you, Terrell, and Phil Siegel right after the doctor's question.
Thank you. Thank you very much for enlightening talk. It's very new to all of us and obviously hard to understand for some, but I still have being a urologist, I'm a very basic person, and I still have trouble figuring out your 4 or 5 inputs into this, making this big database all have a 10 or 15% error rate. What happens to that error rate when you mix 3 or 4 things together and you still got an error rate that's I don't understand how it just disappears.
Well, the error rate does not disappear. What happens is, and I'm going to say this right now, but I would like to have at some point one of our engineers revisit this, but there's a tolerance that's built into the algorithm because we're looking at so many different data points that
I don't know what that means. There's a tolerance built into the database.
So-
Margin of error.
What does
yeah,
it mean?
it's
An
basically
allowable margin of error.
correct.
So we still have the same margin of error.
Not the same.
Right.
Why not?
These are data scientists. They take this large mass of data and they're able to shrink down that's what we're calling a margin of error or a tolerance.
Mm-hmm.
So that when the probability map is, I shouldn't be answering, but I'm checking I understand, okay? When the probability
Actually, you're doing a great job.
is created, then the probability is high that it's accurate.
So it's a probability.
It is a probability map, yeah.
Then
Yes.
the real question that I have is, I just read a New England Journal article about the legal aspects of all of this. And where on earth are we going to ever get, the plaintiff's attorneys are salivating. Because if this program says one thing, your doctor says, no, let's lop it out, and you got all kinds of issues, insurance coverage, it just goes on and on. The article is 6 pages long, and I didn't understand very much of it either, but that's okay. A bunch of lawyers. Where's your guess as where the liability is going to lie?
Well, I mean, from my standpoint, the way I look at this is a complementary bit of information, very similar to how we use genomics and biomarkers when we counsel patients in terms of
Or MRI.
whether or not to make decisions from that standpoint. This just takes a lot of those bits of information and brings them all together so that we can counsel patients on, their potential risk. We use a lot of these similar types of information when we're looking at developing margins for doing a variety of different focal therapy things, and we're doing some in other clinical trials. Are just not as elegant as this in terms of how it puts all of those pieces of information together in one place, all together. And it's such an easy to use, smart way. I mean, if we look at right now, you go from someone's got an elevated PSA. Now we have MRI scan that we use. We have biomarkers, they're urine-based, they're blood-based, and all of them are predictive modeling of what's your potential risk for prostate cancer. When people get diagnosed, now we use a variety of different genomics tests that predict, based on extrapolation of a large body of data, what your next 10 years potential risk of dying for prostate cancer metastasis may be. And here we're taking information based on imaging, and your pathology, and comparing it to what we right now what we typically do when we're doing focal therapy. We're doing a 1 to 1.5 centimeter margin around that. Here is personalizing it based on some wonderful data and some really well done data and some wonderful science to look at how we can really increase the probability that you're going to have a cure rate that is optimized and is matched with prostatectomy data that's been really well validated. And people have looked to try to minimize the standard deviations of like Dr. McEvoy was mentioning, in terms of decreasing those individual error rates so that the total error rate becomes smaller. And hopefully, as we do more and more of this, that will continue to improve as we learn more and more from that standpoint.
Yeah, that's a remarkable advance, and we sure appreciate you guys sharing it with us. I will tell you, the average urologist takes 2 months to learn how to put the gloves on and which finger to put the KY gel on. And so this kind of complicated stuff is going to take some real teaching.
Well, you'd be surprised. I mean, the learning curve for being able to use Unfold AI is very short. It's pretty intuitive. It's not that difficult to learn. The biggest challenge is that getting the information into Unfold AI, and that's also been automated. So it's actually pretty easy.
Yeah, very good. We sure appreciate you guys helping us with this.
Well, I really appreciate this opportunity. I have to go jump on a flight.
Can I ask a quick question?
Sure.
Absolutely.
Like when somebody's getting a biopsy, right? So, like the MRI might show it's target, it's in one location. So, with this technology, would you jump around to some other areas and say, gee, it's going to bounce, it's going to be, to the right or to the left, it's going to be, a couple of millimeters or 3 millimeters. Should I go there? Is it likely that there'll be another cancer?
So I'll tell you how I do a biopsy going into before, when someone has an MRI lesion. And I'll let Carolyn answer how that's extrapolated into this information. So if someone comes in with an elevated PSA in our practice, and we've been doing multiparametric MRI-based biopsies since about 2012, 2013, we started getting our protocols together in partnership with the NIH and University College London, getting those in place. And we did our first fusion biopsies in 2014. And there's data that show the combination of a fusion targeted biopsy with a standard biopsy together, the probability of missing a Gleason 7 or higher cancer is less than 6.7% of it. That's a negative predictive value, which is really wonderful. So what I do is I first target the area of concern, and then I do a standard biopsy on top of that. And the combination of two has served us well in our practice. And we've presented our data. We have almost a 75-76% positive biopsy rate if we have an MRI lesion, and that's, and about a 55% of those are Gleason 7 or higher. So you take that information, and then if you have someone who's a candidate for focal therapy, for example, then you can bring on Fold AI to extrapolate their candidacy by looking at those information. And if they have a small area and somewhere else that has got a Gleason 6 disease, you can then kind of find out whether that's an issue from that standpoint. And I'll let Carolyn kind of speak to how their technology works with how we do the biopsy.
By any chance, do you ever do PSMA in conjunction with the MRI to determine cancer?
So I use PSMA a lot as a staging tool from that standpoint. In the community practice, I would love to use it as a diagnostic tool prior to that, but getting that paid for would be very, very difficult. The guy who was instrumental in doing some of the first big trials to get PSMA funded in the United States is a friend of mine, and him and I have kind of talked about, the PSMA-based MRI, PSMA as a fusion biopsy. So we talk about that anytime we see each other. But right now, getting a PSMA PET scan done beforehand as a diagnostic tool, getting that funded would be really, really difficult. But yeah, it's something interesting that we talk about all the time amongst ourselves.
Well, thank you. Doctor, I know you have to catch a flight.
No, I really appreciate everyone and the opportunity. Carolyn, thank you for the invitation.
Thank you.
Everyone, thank you guys for the invitation, and it was a real pleasure. And sorry about the creepy background and the noise if it was too loud. Our light here from that standpoint. But this was a wonderful, wonderful opportunity to talk about an amazing technology that I have been beyond excited to use. And I look forward to how it helps us to help our patients and all of us become smarter in how we manage a disease that is a real honor to be and a privilege to be a part of men's journey through prostate cancer, because it's not easy. And to be a part of those discussions and helping them figure out what to do has been really the passion of my career. And I've learned a lot from my mom and how she's managed breast cancer to help that process for men, because it's not easy. And I would urge you guys not to take it lightly, to use technologies like this to help you make the decision that's right for you and not rush into any decision from that standpoint. So I appreciate the opportunity. Thank you.
Thank you, and
We wish
safe
a good,
travel.
safe flight. And I know we have other questions here for Carolyn.
Thank you.
We're going to start with Terrell, and he wants us to walk him through how we're using AI on metastatic prostate cancer.
So in our context of using AI, basically what we're doing is we're taking those inputs that we had discussed before, the fusion biopsy, the pathology, the MRI imaging, PSA, and the demographics, and it's going into Unfold AI to generate those two AI, the AI algorithm, creating the cancer estimation map and that lesion contour. So we're using that to basically show the probability of where the cancer is, and then using that information to guide the patient along the care path. It can also be utilized to guide treatment, because the lesion contour can be overlaid onto several devices that are utilized for focal therapy or for external beam radiation.
Terrell, did that answer your question?
Yeah, because I had a prostatectomy, and all the slides I saw just dealt with the prostate, and I was wondering if this tool would be used to help to determine treatment for Mets, for advanced cancer.
No, we're some day down the line, I don't know how many years from now, we may be in other organs, but it's pretty much right now all we're doing is prostate.
Okay, thank you.
Yep, you're welcome.
Bill Siegel wants us to walk him through how a patient can get started with using Unfold. Maybe we ask our medical care provider about it, our physician, our urologist, and we know that we're working on getting Medicare to help pay for it. But what are the payment options for Unfold AI, assuming that our provider wants to use it?
Well, the first question was, how do you get started using Unfold AI? And basically, you need to locate somebody in your area that's offering it. Right now, we have just a few locations. For the people that are in Orange County, UCLA is your closest location. We have a couple of other ones in the hopper that may be closer. But right now, UCLA is your option. And you need to have had a fusion biopsy. That's the number one thing that you're going to need to have, and access to the data from the fusion biopsy. So if you have not had one, you're going to need to be rebiopsied with that data, but you want to make sure that you're re-biopsied at the location that has Unfold AI, because that will be your easiest solution. And then the second question was regarding how much it costs. And basically, we are in the works to get reimbursement. As I mentioned, we're on target and position to potentially get it in July. But in the meantime, it is going to be a cash pay option, and it is $5,000. But that is in par with MRI, PSMA, Decipher, all of the other tests that are out there.
Outstanding.
So you mean oh, go ahead. I just want to ask about, we can't hit my urologist at GW can't use it?
If they don't have it, they can't. We can, certainly.
Well, they have that's the only kind of biopsies we get are fusion biopsies. So if they're capable of doing that, then they could use AI.
Yeah.
Okay.
Yeah, exactly.
I wasn't clear if it had to be done in a particular place. It just has to be the right kind of biopsy.
It has to be the right kind of biopsy, and we have to be able to access
and all the data. Right. And
Yep.
they find that out in advance. Okay, thank you. Sorry, Neil.
No. That's fine. That was a good question. Because we want to know how to jumpstart this process. Let's see here. We have some more questions here from again, here's Bob. Any plan to extend this situation of recurrence post initial treatment? Okay, so are we talking here about recurrence in the gland, or have we answered this question with metastatic disease, where right now it sounds like we're not set up to use your system with metastatic disease?
Not anything outside of the prostate. But if you're just say, for example, you had a focal therapy, you could use Unfold AI to follow your progress.
Okay. So this is in the gland with focal or SBRT, IMRT. Okay.
As well as active surveillance. There are many men who have intermediate risk disease, GG2 cancer, who are on active surveillance. And Unfold AI would be a tool that you could use to see if there's any type of progression.
Excellent. Keith has an outstanding question. Can Unfold AI incorporate data from a Decipher genomic scoring?
So not at this time. One of the things that we are looking at is some of the different data points that we might want to include in future versions, but not right now.
Okay. Keith has a question that I think I can answer. What is a fusion biopsy? And what we're really talking about here, Keith, is it's a biopsy where we're not just shooting needles into the prostate. It is a multiparametric magnetic resonance imaging guided biopsy, whether that's transrectal or transperineal, because you can also have those with transperineal as well. Did that help, or do you need more information on that?
No, that's good. That helps. Thank you. Yeah, I'm familiar with our discussions about MRI guided biopsy, but I just hadn't heard the fusion term before.
So just to tell you what the fusion piece of the puzzle actually means, there's a 3D data set. If you think of a cube of information, and if you think of a deck of cards, and each card is an image. So you have an MRI deck of cards, and you have an ultrasound deck of cards, and you basically combine them one card after the other, and then you fuse them together. So if all the cards are stacked neatly together, then you've combined both of them. And that's what the fusion is. So it's the MRI then is overlaid on the ultrasound, and the region of interest that the radiologist has delineated on the MRI slice is what actually is on the live ultrasound machine. So when you're panning in and out of on the ultrasound machine to look at the prostate from the apex to base, the MRI slices are actually following with you. And that's what it means to have it fused. So that region of interest or that target, they're able to see all the way through the prostate. Does that make
Thank you.
sense?
Yes, yes, thank you.
There's some smart people out there who figured all this out.
Yeah, there are.
I want to open this up. Has anyone posted a question that I have not gotten to?
Yes, Ira. I'm curious, how does Theranostics work with you in the future of this program, and how does it change the future for treatment?
So again, that's something that we are not involved with right now. I'm not 100% sure how that would be incorporated. But right now, anything's on the table as far as what we might incorporate in the future. I can't answer that at this moment.
Carolyn, could you talk to the improvement in results of the of focal treatment using Unfold AI versus not using Unfold AI?
Well, basically, the visual of where the cancer is and what the actual tumor volume is, the extent, is going to help focal therapy because, one, it's going to let you know, are you an actual candidate for focal therapy?
Right.
You know, a lot of times when you're looking at the MRI, you say, oh, well, I'm absolutely, going to get focal therapy because this is going to be perfect for me. But Unfold AI is revealing some information that's going to say to you, wait, maybe I'm not. And one of the biggest things, and one of the things that creates a failure, is when the cancer goes across the midline. And even if you get what's called a hemigland ablation, if you don't realize that the cancer went across the midline, you're going to miss it and you're going to leave it behind. And you could potentially get a recurrence. So the more information you have about what's happening in your prostate, the better your odds are that you're going to have a good outcome. I think Bob had a question.
Can you hear me?
Yes.
I think the scary takeaway I got from this was that slide you showed of the MRI with a small lesion, but your model prediction showed a larger region of probability cancer. And then the prostatectomy pathology slide showing it was indeed larger. I worry that, my 1 centimeter MRI tumor is going to be 2 centimeters in reality. So this is a very useful tool to cover that situation.
Yeah, the tough part is even an incredibly skilled radiologist can miss it because it's invisible on MRI. So
Yeah.
it's just an unfortunate thing with the MRI. It's that it's not giving you the information that you're expecting.
Is the database that you use based primarily on prostatectomy pathology slides?
The validation piece?
Yeah.
Yes, basically, well, we did a validation study with pathology, whole mount pathology, and it was we did very well. The accuracy is very high; it's in the 91 percentile.
Excellent.
For the index lesion, yes. So basically, after that, it was all the data points that have gone in.
Okay, thank you.
Have I missed anybody, or does anybody else have a question? Well, this has been an amazing hour. And before I call for the last questions for the final time, we need to stay in touch. And we need to stay current on what your organization is doing. Do you have a newsletter you send out?
We don't have a newsletter right now, but all of our updates are on our website.
Okay. Okay. Please keep us in mind if you ever develop a newsletter, and I'm going to bat some ideas around with our board of directors about where we go from here.
Okay, that sounds great.
Thank you very much for taking your evening with us.
Oh, no, it was a pleasure.
Makes and what's amazing about this technology is how smart the teachers were to make this a very, very amazing student out of the gates.
Yes.
And with the thought process going into continuing it to make a ongoing smart student that's going to continue to get smarter. And that's what has made me very impressed about it and it got me interested in being a part of this, and feel very fortunate to, as a community urologist, is very, very, my passion is prostate cancer, to be a part of this.
So are you part of Avenda or a very enthusiastic customer user?
The latter. I mean, I hope to be, more and more, a part of the education process of learning more and more and being, helpful in this process. But, my interest in prostate cancer and things like this kind of start with a little bit of background. My mom, both my parents and my brother are all in medicine, and my mom is a kind of like a world-renowned pathologist. And, prostate cancer is probably a few decades behind where breast cancer is.
Yeah, yeah.
And so we're beginning to make really rapid strides, especially in advanced prostate cancer, in terms of bringing together genetics and genomics and our understanding and understanding what we don't know and what we need to know to move that forward. And so taking that backwards in terms of the diagnostics, how to diagnose better, and take that diagnosis into who to treat, who not to treat, what to do with that, so that we can be more precise and accurate and better counseling and how to treat people through the whole spectrum of the diagnosis of prostate cancer. Is really, I think, taking what people with breast cancer do through that spectrum, and hopefully we can use technologies like this along that pathway. And so I think this allows us to not only be smart in terms of how we counsel patients and learn about the disease we're talking to our patients about, from the beginning of that conversation, but I think it allows us to continue to be this continual learning project of every day is a school day, so we can learn what we need to learn and be able to teach ourselves and our colleagues, our radiologists, our urologists, our radiation oncologists, and potentially continue to learn what we need to do better and from this aspect going forward. So I think this is going to be a great way to not only learn more and do better in terms of how we manage the disease, but learn what we need to learn as we learn more from the application of this moving forward. Very similar to what breast cancer has done over the past several decades. And hopefully we engage people to become better advocates for their own disease as they see how this changes their management by unveiling the truth of their disease as they make their decisions. And what's amazing about this technology is how smart the teachers were to make this a very, very amazing student out of the gates.
Yes.
And with the thought process going into continuing it to make a ongoing smart student that's going to continue to get smarter. And that's what has made me very impressed about it and it got me interested in being a part of this, and feel very fortunate to, as a community urologist, is very, very, my passion is prostate cancer, to be a part of this.
So are you part of Avenda or a very enthusiastic customer user?
The latter. I mean, I hope to be, more and more, a part of the education process of learning more and more and being helpful in this process. But my interest in prostate cancer and things like this kind of start with A little bit of background, my mom, both my parents and my brother are all in medicine, and my mom is a kind of like a world-renowned pathologist. And, prostate cancer is probably a few decades behind where breast cancer is.
Yeah, yeah.
And so we're beginning to make really rapid strides, especially in advanced prostate cancer, in terms of bringing together genetics and genomics and our understanding and understanding what we don't know and what we need to know to move that forward. And so taking that backwards in terms of the diagnostics, how to diagnose better, and take that diagnosis into who to treat, who not to treat, what to do with that so that we can be more precise and accurate and better counseling and how to treat people through the whole spectrum of the diagnosis of prostate cancer is really, I think, taking what people with breast cancer do through that spectrum. And hopefully we can use technologies like this along that pathway. And so I think this allows us to not only be smart in terms of how we counsel patients and learn about the disease we're talking to our patients about from the beginning of that conversation, but I think it allows us to continue to be this continual learning project of every day is a school day, so we can learn what we need to learn and be able to teach ourselves and our colleagues, our radiologists, our urologists, our radiation oncologists, and potentially continue to learn what we need to do better and from this aspect going forward. So I think this is going to be a great way to not only learn more and do better in terms of how we manage the disease, but learn what we need to learn as we learn more from the application of this moving forward. Very similar to what breast cancer has done over the past several decades. And hopefully we engage people to become better advocates for their own disease as they see how this changes their management by unveiling the truth of their disease as they make their decisions.